All right, we are back. Our next presenter is someone that has been a part of our department for a couple of years now, 2-3 years now. And I want to introduce you to Dr. Justin McLawhorn. He is a PGY 3, or second year resident, getting ready to be one of the chief residents in dermatology here at the University of Oklahoma. And he graduated from the University of Arkansas for medical sciences, College of Medicine. And he then went on to internship here at OU and is now within our department. He is just a stellar resident, and we are just so proud of him to present some research that was in collaboration with Tulane University, as well as our own institution. And so now I'm going to take it away to Dr. McLawhorn. He is going to present on medical students' ability to diagnose common dermatologic conditions in skin of color.
Thank you so much, Dr. Allen. It really is a pleasure to be here, and it's going to be so hard to follow all of the talks that we've had today. I'm going to go ahead and bring up my presentation. In true Oklahoma fashion, we are having a thunderstorm move over at the current point in time, so you may hear some thunder and see a few bolts of lightning coming back through behind me, but that just kind of adds to the flavor of being virtually in Oklahoma. So as Dr. Allen said, I'm Justin McLawhorn. I'm one of the PGY3 residents here. And I will be presenting today on medical students' ability to diagnose common dermatologic conditions in skin of color. And so I don't have any relevant disclosures to discuss. These are our professional practice gaps, of which I will leave that to you to look over. Here are our learning objectives. We're going to focus on comparing medical students' ability to identify common conditions between patients of skin of color and lighter skin phototypes, and identify several common dermatologic diseases in patients with skin of color that are difficult to diagnose by medical students, and also illustrate the need to prepare physicians to treat diverse populations to help reduce racial health disparities. So in terms of healthcare disparities, studies have shown that there are substantial differences in dermatologic care in minorities, those that are less educated, those that have lower income, and those that are uninsured. And although the etiology of these discrepancies have not been fully elucidated, we know that patients with skin of color utilize dermatologic services at a lower rate than patients with lighter skin phototypes. It's estimated that nearly 92% of patients seen by a dermatologist within an outpatient setting will identify as white. This may be due to barriers in access to care, also lack of awareness regarding dermatologic disease among patients with skin of color. And this has been demonstrated by skin cancer morbidity and mortality in these patient populations, which is disproportionately higher than in non-Hispanic whites. Another possible explanation is that educational programs, marketing campaigns, societal objectives have emphasized skin cancer prevention more than in inflammatory or infectious dermatoses, thus inadvertently excluding some minority groups. So a lack of familiarity with skin disease and skin of color is a physician-dependent factor that may also contribute to worse outcomes when caring for these patients. Not only do medical schools devote less than 1% of their medical education to dermatologic disease, but the education that's offered may be weighted towards disease presentation in lighter skin phototypes. In a recent survey, nearly 47% of dermatologists and dermatology residents reported that their medical training that included their residency training was inadequate in preparing them to address the skin conditions in patients with skin of color. And unfortunately, there's little research on the adequacy of the current dermatologic training. So what did we do? We attempted to address the current medical education as it pertains to the diagnosis of skin disease in patients with skin of color. We distributed an electronic survey to all medical students, both at Tulane and the University of Oklahoma College of Medicine. Both of these medical colleges have included or include didactic lectures in dermatology in the preclinical years and offer dermatology rotations within the latter clinical years. We created 2 versions of a 10-question survey. Each provided a Kodachrome of some of the most common skin conditions that are taught or seen in a preclinical dermatology course or on a clinical dermatology rotation. And each version of the quiz was equally divided between patients with skin phototypes 1 to 3 and skin phototypes 4 to 6. So here's an example of some of the dermatoses that we showed. Contact dermatitis, verrucae, urticaria, and also tinea, and psoriasis. These were all provided by Dr. Marina at Tulane. So we distributed surveys to 1,420 students. Of those, 177 actually completed the study in its entirety. Of those, 91 came from Tulane and 86 came from OU. There were no significant differences between the OU and Tulane medical students when we're stratified by year. As you may expect, the students who were preclinical scored an average of about 50% correct, where those who were clinical students in their 3rd or 4th year of medical school scored an average just a little over 60% correct. And here's what we found. Across all skin types, the diagnosis most frequently identified were herpes zoster, and this came in at 83.1%, psoriasis at 81.9%, and also atopic dermatitis at 80.2%. The conditions least frequently correctly identified were verruca at 26.6%, contact derm at 30.5%, and squamous cell carcinoma also at 30.5%. We also found that conditions with the greatest disparity in visual diagnosis amongst medical students based upon Fitzpatrick skin phototypes were squamous cell carcinoma, where the discrepancy was the largest, 14.9% versus 45.6%, and that was statistically significant. Also urticaria, 57.5% versus 82.2%, and atopic dermatitis, and that was 74% versus 86.2%. Students were more likely to correctly identify tinea versicolor in patients with skin of color compared to patients with lighter skin phototypes, and that's 62.1% correct versus 42.2% correct. And the increase in the diagnostic accuracy for the tinea versicolor, we think likely involves the more prominent pigmentary change that may be seen in patients with skin of color, or the PIH. In lectures and textbooks, photos that teach tinea versicolor may be presented more frequently in patients with skin of color to more clearly demonstrate the associated pigmentary changes. All right. So despite movements to educate the general public and improve the quality of medical education, we still have many knowledge gaps that need to be filled. Improving the quality of care in patients with skin of color will require a multifaceted approach. One area to address would include improving the scope of graduate medical education to include more discussions and education in skin of color. There's also a need to increase diversity of enrollment in clinical research trials and make them more representative of populations that are most affected by each condition in order to have evidence-based treatment recommendations for each skin phototype. And arguably, the inclusion of symposiums such as this into residency or medical training can help to not only increase cultural competency, but also increase familiarity of disease presentation in patients with skin of color. And this ultimately may lead to improved health outcomes for these patients. So by 2043, no single ethnicity will make up more than 50% of the United States population. And it is imperative that medical education advances with the evolving demographics of our communities, particularly as primary care providers and dermatologists will increasingly encounter dermatologic disease in patients with darker skin phototypes. Dermatology is at present only a minor part of many medical school curricula, with most medical schools investing a median of 10 hours into lectures that have been integrated mostly into the preclinical years, some with little to no clinical instruction within the clinical years. And it's not known how frequently these curricula will provide dermatology instruction that address the presentation and management of these conditions, specifically as they relate to skin of color. And even worse, the educational bias favoring skin of lighter phototypes has also been perpetuated within the scientific community. As mentioned previously, there's been recruitment of cohorts into clinical trials that don't adequately represent the racial and ethnic diversity of the United States. And as a result, a lot of the information regarding incidence, prevalence, risk factors, management, prognosis for many of the dermatologic conditions are weighted towards patients with lighter skin phototypes. And these may not always be applicable to patients with skin of color. And as more dermatologic conditions are managed by primary care physicians and mid-level providers, a thorough undergraduate curricula for students going into all specialties may benefit those patients that have limited access to a dermatologist. A variety of learning opportunities, including table-based learning, bedside rounds, didactic lectures, and arguably skin of color symposiums or meetings, should be offered as routine facets of a graduate medical education. A light skin biased education is not sufficient. We can and we must do better to prepare our medical students, residents, and other providers for our increasingly diverse society. Learning how to correctly identify the characteristic morphology of common lesions and a variety of skin phototypes is but the first step in reducing dermatologic disparities faced by patients with skin of color. And here's first part of my references and second part. And so you can help us to spread the word by sharing our article. It's referenced here within the JAD. If you have any questions about this presentation or project or advice for future projects, please do let me know. I also want to give a special thank you to my collaborators, in particular, Dr. Allen, Dr. Morris, and Dr. Eswina, who I believe are all here on the Zoom call with us today, because we could not have pulled this off without their help. And with that, I thank you for your time and attention.
Excellent. Thank you so much, Justin. I tell you, you did an awesome job on the whole layout of the research. He spent a year with us as a research fellow, and this was one of the projects that he did and to its completion. And so very telling information, just to add it to the body of what we already know. And, you know, we're finding this around our university academic institutional settings, especially in medical school. And I know that even here at OU, we have a diversity curriculum task force that is currently working on revamping the medical school curriculum from first year all the way through fourth year, looking at unconscious bias training, increasing the diversity within the medical students, but also the patients that they are going to be exposed to in their OSCEs and other type of situations where they are coming into contact with not only African American, but Hispanic patients, different religious groups, LGBTQ community, so that they have a well-rounded exposure. And we in dermatology, of course, I know in other institutions also give lectures, and we strive to include those skin of color lectures as well. And anybody in the chat have any questions or comments of what they're doing at their own university?
Well, actually, this morning was very apropos. I was taking, as being the director of MOS, I had to take these courses on diversity and inclusivity and cultural competence. And I have to laugh because, you know, I've been living that all my life. Yes. I don't know how many times I've been asked, oh, but Dr. Perez, you don't look Puerto Rican. It's like, so how Puerto Ricans are supposed to look? And, you know, like, remember, also, when I went to Columbia Presbyterian to do my first fellowship in immunology, the rubicund Irish security guard told me that are you a Puerto Rican doctor? And I told him that I was the eighth wonder of the world. Because, obviously that's apparently unheard of. But in reality, I learned this morning about, the idea, like the line that you don't look Puerto Rican, those are called microaggressions. And we all our lives have been experiencing them. And now we have to learn how to respond to them in not an aggressive fashion, not in an anger fashion. We need to start projecting, trying to bring the person that is directing the microaggression to us, be that another colleague or, a patient, many times they are patients, try to bring them out to realize the situation so that we can all learn from our daily experiences. And one of the things that I learned this morning was, somebody was kind of scenario in which the white resident was passing the entrance, the hall in the hospital, and there was a group of Puerto Rican patients speaking Spanish, and when he got to his attending, the attending is Puerto Rican, he expressed his concern about, these people not speaking English. Why don't they speak English if they're in the United States? And how, as yourself, if you are that Puerto Rican doctor, how you're going to take that information and make it a learning experience for everyone. And the idea was, to go and say, well, always put it from your point of view. I perceive that you have some problem with the patients that you're going to take care of, and maybe we can discuss your discomfort, because those are going to be the patients that you have to take care of. So we have to solve this before you take care of the patients.
That's exactly right. You are exactly right. Anyone else? Wonderful. Thank you so much, Justin. Great reporting, a thorough summary of the research that needs to be continued.